ovarian cancer is something that I feel very strongly about. I think it's a cancer that doesn't get the same limelight that other cancers get. It doesn't get the same airtime on the TV as breast cancer, and I think it's a cancer that causes a lot of suffering in this country, and I think it's a cancer that we can do a lot better in treating. So I'm delighted to see that this is the start of something big here, that we're having an annual education forum like this. So some of what I'm saying may be repetition, but hopefully that's useful just to reinforce what our previous speaker has said. In terms of statistics, about 340 women in Ireland are diagnosed with ovarian cancer each year. So that's less than, we'll say, lung cancer, where there's 2,000 patients each year, but still it's a disease that, again, we need to improve on our treatments. That boils down to about 1 in 70 lifetime chance of developing ovarian cancer. And although the average age is in women in their mid-60s, ovarian cancer can strike at any age, and we've had patients in their 20s and patients in their 80s. So age alone shouldn't be a reason not to get checked out if you have worrying symptoms. As we've heard, unfortunately, ovarian cancer is a disease that's tending to be diagnosed in the later stages. So the majority of women do not have early stage disease, they have advanced disease. And it's frustrating for everybody. It's frustrating for the women, because I suppose there's a feeling that the system has let you down, that you've got this problem, it's presenting late. But I guess the difficulty is your symptoms are usually quite vague. So maybe a bit of abdominal bloating, a bit of urinary frequency, a bit of indigestion. And as we've heard, the problem is that the ovaries are very small. They're about the size of a small plum deep down in your pelvis. Unless you've got a very big swelling there, you're just not going to notice it. So unfortunately, we need to find better ways, and we heard that in our scientific session earlier. We need to find ways of diagnosing ovarian cancer before it's spread. I'm not going to put many gruesome pictures here today. I just wanted to give you, I suppose, a sense again of who the enemy is. This is what an ovarian tumour looks like, and I suppose if you look at the little measurement beside that, that's 5 centimetres little measurement, so the tumour itself is 15 centimetres. It's not unusual to see a tumour that size in women with ovarian cancer, because it has to get that big before it presses on anything and causes symptoms. Under the microscope, we've heard it's not just one disease, there's a range of different types of ovarian cancer, and the pathologist will look under the microscope and try to get as much information as possible so we can tailor our treatments so that the right woman gets the right treatment to get the best result. I suppose in due deference to my surgical colleagues, it's important to point out that the surgeons get a lot of credit because they go in early, they get fast results, and they make people feel better very quickly. So I suppose if to use a sporting analogy, the surgeons are like the sprinters. They go in there fast, they get a quick result, and they're very good at what they do because they have been practicing for hundreds of years. Radiation oncologists, I suppose, have been doing what they do for about 100 years. Their strength is they get to play with all the top technology. They really have excellent machines to really make radiation safe. Medical oncology, I guess, are the newest attendees in the treatment of cancer. Chemotherapy was only developed in the 1950s, so you have to give us some chance to get better and get more sophisticated in what we're doing. We are at the start line with lots of new ideas, lots of new treatments, and we have to really learn how to use these to the best advantage. So forgive me if some of this is quite basic, but again, I just wanted to be sure that everybody has a good understanding of what the treatments are. So what is chemotherapy? So chemotherapy is basically the name that's given to medicine that's used to treat cancer. Like any other kind of medicine, it can be given in many different ways, so tablets, injections, infusions, and it's important because sometimes you go in with expectations that your treatment will be the same as somebody else's. Some treatments are given once a day, some are once a week, some are once a month, and the treatment can go on for varying periods of time. I suppose the average is about 3 to 6 months of treatment, but some of our maintenance treatments go on for a year. So it's important that you understand that your case will be a decision that's been derived after a lot of discussion and consideration. One of the, I suppose, the things that frustrates people and frustrates us is that the time it takes from finding a chemical that you think is going to be really good for curing cancer and actually developing a drug that you can give to a patient is a long, long process. And I suppose from the time that you get the chemical, you screen it to see, does it kill cancer cells in test tubes? Is it a safe drug to actually bring it to people, to bring it to people with cancer and taking it through a safety testing clinical trial program, to actually having a medicine that we can give to patients, that takes 5 to 10 years. So I suppose you read in the medicine supplement in the Times every whatever day it is that there's a big breakthrough in the lab and this drug looks really promising, but unfortunately it's going to be some time before those drugs are available to patients in the clinic. So I suppose one of the main emphasis I want to put across to you today is that if we want to get access to medicines at an earlier stage, we have to be able to give medicine to people during the testing process. We need to be able to have access to clinical trials so that our patients can have the same opportunities to benefit from drugs as they're being tested before waiting 10 years until they're on the shelves. How is chemotherapy given? As I said, some chemotherapy now has been refined into tablets, so you can actually take it at home, which is convenient. But a lot of our standard treatments are given by infusions. Usually that's a drip into your arm, and it involves being in the day ward and connected up to a drip. If you have very bad veins, that's not a problem. We can always give the treatment through one of our access devices, a little portacath that's put in under the skin, just in the top part of your chest, and that does away with the worry that some people just can't cope with drips and that. You heard from John that chemotherapy is used in different situations, and I suppose I just wanted to get the terminology clear because it can be quite confusing. In ovarian cancer in particular, most women will need some form of chemotherapy at some stage. Really, I suppose the women who won't need chemotherapy, please God, are the people of really early disease, so stage 1A or stage 1B disease, just confined to the ovary, may be cured with surgery alone and really won't benefit enough to put them through chemotherapy. But for everybody else, chemotherapy is probably going to help in some way. If the disease is really bulky disease and it's going to be a very difficult operation, then it's sensible to give the chemo first. And as you've heard, we can sometimes get spectacular results with chemotherapy, so that when you open up the tummy afterwards, there's no visible disease. So chemotherapy first before surgery is called neoadjuvant chemotherapy. The standard approach, though, is to try and do the surgery first, get as much of the disease out as possible, and then go in with post-operative chemotherapy, and that would be the standard approach. I suppose the difficulty in ovarian cancer is that even after a great result with first-line treatment, sometimes the cancer comes back. And in that situation, we use chemotherapy again in what's called the palliative setting, where you're trying to shrink the cancer as much as possible and help people to live well for as long as possible. In terms of the standard treatments, I guess the standard treatment that we use is a combination of 2 chemotherapy drugs, and that's been the standard of care since about the mid-1990s. And a lot of our work has been to try and refine those treatments and make them work a bit better, try and tweak the formula. But effectively, the 2 drugs are Taxol, which is made from Pacific yew tree bark. If it's of any interest, it's one of the Celtic Tiger things that Ireland used to be the world centre for production of Taxol. The other backbone drug that's been around for many years is platinum, which is derived from the heavy metal, the precious metal platinum. And carboplatin is more user-friendly than the original cisplatin drug. So those 2 drugs are really the standard of care for women with newly diagnosed ovarian cancer. Obviously, not everyone's fit for chemotherapy, and there are side effects. So your case would be individualised, and if somebody has frail health or diabetes or some other problems, the drugs would need to be altered. Can you expect side effects? I suppose the short answer is probably yes, but it does vary hugely. Some people sail through chemotherapy, they get the anticipated things like fatigue and probably hair loss in the majority of cases. But a lot of the side effects we can predict and we can try and prevent. So nausea is much less a problem than it used to be. Allergic reactions, which really were almost defeated Taxol in the initial results. The stuff that Taxol is dissolved in is very allergenic, and people used to get like an anaphylactic reaction. But we manage those now, so chemotherapy safety has certainly improved. As I said, when we've got 2 drugs that we know work really well in a lot of patients, what we've tried to do over the last 15 years is see could they be edited in some way or made a bit more effective. And one option is to give the drug through a different route. So if you're reading about this, you may read about intraperitoneal chemotherapy, where at the time of an operation, at the time of the original surgery, a catheter or tube is put into the tummy. And as you've heard, ovarian cancer tends to spread within your tummy. So instilling the chemo directly into the tummy seems like a good idea. The original studies showed that it was a fairly tough treatment, so it's not for everybody, but it does seem to delay treatment coming back. Just to show you, this is just a diagram of what the tube looks like. It's a little tube that would stick out of the tummy, and it's used for putting chemo in addition to getting chemo in through a vein. I think it's an approach that's going to get more airtime because the 10-year results from that study have come out and they do look quite promising. So if we could get a safer, less toxic way of giving this, or a safer drug to give, I think that may be in addition to what we're doing already. One of the problems is, as I said, that even after a great result with chemo, some people have a relapse of their disease or it grows back. So it's tempting to think, if we kept people on treatment, could we keep the cancer away for longer? And that would be the idea for maintenance treatment. I suppose there's been mixed results with that, and the only chemo drug that seems to work in the maintenance setting is Taxol, but its real problem is it causes nerve damage, so people get numbness in their fingers and toes. So it's not an approach that's really caught on because it's quite toxic. I think the newest addition to that is, instead of using chemo as an extended maintenance, to use some of the newer targeted treatments. And the treatments I think that probably are quite promising, and I'm going to talk to you a bit more about them, are drugs that affect blood vessel growth, drugs like bevacizumab or Avastin and pazopanib. And going back to the clinical trial thing, 10 Irish women were involved in a big maintenance study, so finished standard form of chemotherapy, had a good result, but then went on to a year of either a placebo, which is a dummy tablet, or pazopanib, the real drug. And the results of that study are going to be presented next month in Chicago, which is the biggest annual oncology meeting. So hopefully, if that shows an improvement, that may be an option as a preventive treatment. I'm not going to get too technical, but targeting blood vessel growth has been, I suppose, one of the biggest breakthroughs that I think has happened in terms of treating ovarian cancer and trying to get better results. Tumours need blood. Tumours need to tap into your blood supply and take your nutrients from you. And one of the things they can do is produce a growth factor, a chemical that allows them to grow extra blood vessels that will feed the tumour. And what's been found is that ovarian cancers in particular, and this goes back to one of the questions from the floor, ovarian cancers in particular produce a lot of a growth factor called VEGF. They have high levels of VEGF, and that can have many effects on the ovary. It can turn benign things into malignant things. It can cause ascites to build up by making blood vessels leaky, and it can cause cancer secondaries to spread. So VEGF seems to be important in making ovarian cancer grow. So it makes sense if we could find some way of cutting out VEGF or blocking it getting to where it goes, and we could shrivel the tumours by blocking their blood supply. So the theory is really good, and does it work in practice? And the answer is, to a certain extent, yes, it does. There have been 2 studies that were looking at adding bevacizumab or Avastin to the standard chemo, so giving the standard chemo and then an extension of a year or 15 months of Avastin. 2 big studies, one in the States, one in Europe. And the results are that in some groups of women, it can delay the cancer coming back. So if we could be more sophisticated and work out beforehand who are the women who are going to benefit, I think this is going to be a major change in how we treat women with ovarian cancer. So what happens, you've had a good result, everything's going fine, what happens if the cancer comes back? How do we decide what's the best treatment at that point? You've heard that in selected cases, if you have a cancer that comes back after a very long interval and comes back in a small area, then you could be cured with surgery alone. So that's an important part of the treatment. But if it comes back in a more general way, then it's important for us to look at your history. It's to look at how long is it taken for the disease to come back. If the disease comes back fairly soon, so within 6 months of your first treatment, then using the same treatment again logically is not going to give a great result, because it's probably a disease that didn't go away first time around. If it comes back in 6 to 12 months, there is a chance that platinum will help the second time around. And certainly if it's more than 12 months since you finished your chemo, there's a really good chance that platinum type of chemo will work. So that would be one of the things that will help us make our choice in terms of what chemo to use. So women are divided then into either platinum sensitive disease that comes back after a long interval, or platinum resistant disease. If you have platinum-sensitive disease, then you should have platinum as some form of your treatment, either on its own, carboplatin, or in combination with another drug. And I say we have a range of drugs, which is good. We have a selection of drugs that we try to fit with the woman's general health. And those drugs can certainly get excellent periods of remission again for women. I mentioned Avastin. Bevacizumab is used in the first-line treatment, but there does seem to be a role for it in women whose disease comes back. There's been a couple of studies now looking at giving ordinary chemo or chemo plus Avastin, and there does seem to be an improvement if you add Avastin in some women. So the tougher problem, I suppose, is for those women whose disease comes back early, or whose disease comes back soon after platinum type of treatment. And for them, platinum is not going to give a good chance of working second time round. So I suppose the good news is that the work over the last 15 years has brought up, a good number of drugs that are potentially useful in this situation to shrink cancers. And what we try to do as oncologists is look at which are the drugs that are going to work best, and then look at what is the health of the woman. If she has heart problems, then maybe doxorubicin is not such a great drug. If she lives 200 miles from the cancer centre, giving a weekly drug is not going to work well. And to try and pick a drug that's going to suit the woman's lifestyle and hopefully get a great result for her. I keep talking about this, and I promise I do not have shares in Avastin or whoever manufactures it, but I've seen fantastic results in the relapse setting with Avastin, either with oral tablets like cyclophosphamide or with weekly treatments. And it does seem to work particularly well for drying up ascites. So it's certainly a good drug to have. The downside of it is if you have blood pressure problems or previous clots or things, there can be side effects. The big thing, harping back to it, is that this is a situation where we really need to develop better, more effective, safer treatments. And the only way we'll be able to do that is with clinical trials. So it's really important that organisations like the charities who've put this day together are supported so that we can focus research into ovarian cancer and get better treatments. We're very lucky in Ireland that we have an umbrella organisation that ties all the 8 cancer centres together, and that's called ICORG, the Irish Clinical Oncology Research Group. And ICORG basically coordinate funding all of us in the cancer centres, helping us to join international studies, and allowing women in Ireland the same access to clinical trials that women in the States, women in Europe have. So it's really important that ICORG continues to support cancer research in Ireland. In terms of gynae cancers, we're very lucky in Ireland that we have links into international collaborative groups. As I said to you, ovarian cancer is not the commonest cancer, but it's a cancer that we will only make progress with if we work collaboratively with other countries to try and get results. So I represent Ireland, I represent ICORG in the ENGOT, which is the European Network of Gynecology Trials, and it means that we have an opportunity to tap into any European trials that are ongoing. Derval O'Donnell, my colleague in St James's Hospital, represents us in the GCIG, which is the Gynecologic Cancers Intergroup, which takes in North America. And we're also part of the Gynecologic Oncology or GOG group, which has done most of the work to bring regimens like the carboplatin Taxol regimen to us. So it's important, I suppose, when you're coming to a cancer centre in Waterford in the south of Ireland or in Limerick or whatever, for you to feel that your oncologist is not working in isolation, that your oncologist is working as part of a national team and part of an international team. To show you how that works in practice, and I don't expect anybody's eyesight to be able to read that, but it's just to show you that this month we're opening in Ireland. We're opening Ireland as a site for the ICON-8 study, which is the latest first-line treatment for women with ovarian cancer. It's a really good study. It'll help to answer a lot of important questions about the timing of surgery versus chemo, about the scheduling of chemo. Is it better to give it once a week or once every 3 weeks? And also to see where does Avastin fit into that. So it's an ambitious study. It's a study that could not be done in one country. It's a big international study, and it's a privilege for us to be able to be part of this study, and I'm delighted that it's going to be opening. In terms of people with relapsed ovarian cancer, we're also participating in an ANZGOG study, that's the Australian New Zealand Gynecological Oncology Group, and addressing a really important question in that setting, which is how do women feel when they're on chemotherapy? Does their quality of life actually improve? Are you making them feel ill while you're trying to treat their cancer? So this is an important quality of life question. And so far, almost 80 women in Ireland have enrolled on this quality of life study. So an important question, and again, really useful information for the oncology community. For the future, I'm sure you may have questions, you may have things that you've come across. We're working away with oncology chemotherapy drugs, but I think the more we learn about how cancer develops, the better we'll be able to shut down cancer and try and turn it into a chronic illness like blood pressure. PARP inhibitors are a group of drugs that seem to work very well, particularly in women with inherited ovarian cancer. We mentioned clear cell cancer. That's a type of ovarian cancer that's tough to treat. It tends not to work, to respond as well to chemotherapy. And I suppose the more we learn about it, clear cell cancer also happens in the kidney. And there's a study, the ScotRock study in Scotland, looking to see could kidney cancer type treatments work in this group of women with clear cell cancers. So I think there are new compounds coming along. There's different ways of treating ovarian cancer, and hopefully we'll get answers to some of these quite soon. I wanted to again acknowledge and gratefully acknowledge all the support that we in oncology receive from the government, from the HRB, who fund our clinical trials unit, from the Irish Cancer Society, from the 3 ovarian cancer charities that you've seen today, Ovacare, Emer Casey Foundation and SOC. And I suppose just to give you a very practical example, I'm delighted to see the 2 SOC representatives over here. SOC and the South Eastern Cancer Foundation have single-handedly saved the research programme in Waterford. With the embargo on staffing in the HSE, we've been unable to appoint, and now SOC and Cancer Foundation have provided us with funding to employ a research coordinator who will allow us to open the ICON8 study in Waterford. So this is a very practical example of how money raised in the public will actually help keep cancer research on the go. To remind everybody that teal is the new pink, that ovarian cancer now has a colour. I suppose talking about ovarian cancer is not easy. A lot of people in the community don't know about ovarian cancer. They're a bit embarrassed to talk about ovarian cancer. But I think if we have a focused colour, it makes it somewhat easier to bring up as a topic. And I think this may give the breakthrough that ovarian cancer needs into the public awareness. It will allow ovarian cancer to move up there beside breast cancer and get the recognition it needs, get the energy it needs to find better treatments. And again, to encourage you that in Ireland we want to be part of this, and on the 6th and 7th of September we're launching the Irish Ovarian Cancer Forum, which is the first meeting of its kind in Ireland. It's taking in experts from nationally and internationally to look at what we're doing in Ireland with ovarian cancer and how can we improve. So don't lose heart. We're at a stage where we have good treatments, we have improved survival, and I think there's plenty of work to be done, and the momentum is building. So thank you very much.